Hello, everyone. My name is Gurjot Basra, and I'm the Manager of Patient Programs, Research, and Advocacy at Lymphoma Canada. I'm very pleased to welcome you all to this breakout session on follicular lymphoma, also known as FL. So just before we start, as usual, I just want to go through a few housekeeping items. So this Zoom software does not allow you to access chat features or turn on your microphone. If you have a question, this session will be followed up by a live Q&A session, so please keep your questions in mind and please be sure to attend the indolent non-Hodgkin lymphomas Q&A session afterwards. So to introduce our speaker today, we have joining us Dr. Robert Puckrin, who is a hematologist and staff physician in the Alberta Blood and Marrow Transplant Program at the University of Calgary, with interest in lymphoma, CAR T-cell therapy, stem cell transplantation, and clinical research. So thank you, Dr. Puckrin, for joining us today, and you can get started as soon as you're ready.
Well, thanks so much for having me, and hello, everyone. I'm happy to be here today to provide an overview on follicular lymphoma, also known as FL. So follicular lymphoma is the second most common type of non-Hodgkin lymphoma after diffuse large B-cell lymphoma. And it's characterized as the most common indolent or slow-growing form of lymphoma. This is a lymphoma that typically affects the B cells. It can often be without symptoms at diagnosis and take many months or years to evolve before it may even be detected by a patient because of its slow growing nature. Different lymphomas originate in different parts of our lymph nodes, but follicular lymphoma, as you can see here, typically originates in the center or the germinal center of the lymph node. And if you take a biopsy of this lymph node and look under the microscope, you can see these circular follicles of lymphoma cells kind of filling up the lymph node and invading surrounding areas. So that's what follicular lymphoma actually looks like under the microscope, and this is where the name is derived from. Follicular lymphoma is a fairly common type of malignancy. It's diagnosed in around 2,000 or 3,000 patients in Canada every year. It typically affects people in their mid-60s, but it can technically occur at any age. For the most part, we don't understand exactly why follicular lymphoma happens, and in general, there's nothing that a patient did to develop the disease, but it's probably related to a combination of risk factors. Developing older age is the main risk factor for this lymphoma, but other risk factors could potentially include a family history, certain exposures in the environment, like certain chemicals, for example, and some other risk factors like immune suppression. The symptoms of follicular lymphoma can vary quite a lot between patients. The most common symptom, though, is for enlarged lymph nodes to occur. They typically are small in size and can be very slow growing over many weeks, months, or sometimes even years. And the lymph nodes, if they remain small, often actually don't cause any pain or other symptoms. Sometimes the lymph nodes can become quite enlarged, especially in the abdomen, or the lymphoma can affect other areas like the spleen and cause an enlarged spleen. And that can result in a sensation of fullness in the abdomen or some abdominal discomfort, or sometimes difficulty finishing a meal because of the spleen pressing on the stomach. In some cases, the lymphoma can also affect the bone marrow, which can lead to low blood counts, like low hemoglobin or anemia. Low platelets as well can occur, or low white blood cells if the bone marrow is very affected. And then in some cases, the follicular lymphoma can also result in symptoms like fatigue or what we call B symptoms, such as fevers, night sweats, and in some cases, weight loss. So how is the diagnosis made? Well, if the patient does develop enlarged lymph nodes that persist over time, then a biopsy is typically done to take a small piece of the lymph node. And then under the microscope, we can confirm that this is indeed follicular lymphoma. The next most important test would be to do an imaging scan to determine exactly where the lymphoma is present in the body. The type of scan done might vary between patient and hospital, but we'll oftentimes use either a PET scan or a CT scan to properly assess the areas affected by the lymphoma. A number of other tests may be done at diagnosis as well. So we often do a panel of blood tests, including blood counts, to see if there are any signs that the bone marrow may be affected by the lymphoma. We also check the function of the different organs in the body, like the creatinine to measure the kidney function, as well as certain tests for liver function. We have some tumor markers that we can use for follicular lymphoma. One is called LDH, or lactate dehydrogenase, and the other is called beta-2 microglobulin, or B2M. These aren't perfectly reliable tumor markers. They can go up and down for a number of reasons, but they sometimes can be elevated in some patients who have a high amount of lymphoma present in the body. At diagnosis, we'll also oftentimes screen for certain viral infections like hepatitis B and hepatitis C. These viruses can sometimes increase the risk of developing lymphoma, or they can also reactivate and cause infection if a patient starts on chemotherapy. So we'll often screen for those before starting any immunosuppressive treatment. And then some cases might require a bone marrow biopsy to be done to see if there is any signs of lymphoma in the bone marrow, but it isn't routinely performed at diagnosis in all situations. So how exactly do we stage follicular lymphoma? It's quite similar to other lymphomas. So stage 1 refers to a single enlarged lymph node. Stage 2 refers to more than one enlarged lymph node, but occurring in the same half of the body. So there might be 2 or more lymph nodes in the neck and the chest, or 2 or more lymph nodes in the abdomen and pelvis area. Stage 3 refers to having enlarged lymph nodes throughout the body, the neck, the chest, and the abdomen. And then stage 4 refers to when the lymphoma has spread to other organs outside the lymph nodes or the spleen, which is most commonly the bone marrow in follicular lymphoma. But I would emphasize that staging for lymphoma may not be as critical to prognosis as in other types of cancer. And regardless of the stage, follicular lymphoma does tend to be quite treatable. And the prognosis is usually good for patients who have stage 1, 2, 3, or 4 disease. So that leads us to a discussion about the actual prognosis of follicular lymphoma. So in general, follicular lymphoma is considered incurable with most treatments, and that's because the disease does have a tendency to relapse or recur over time. But the disease is considered very treatable. We've got many effective treatments that can put the cancer into remission where it is no longer active, and it will often stay away for many years at a time. And as a result of that, most patients with follicular lymphoma do have a very good long-term prognosis, and many people actually have a fairly normal life expectancy. At some point, perhaps 5, 10, 15 years after the first treatment, the lymphoma may come back, but there are many treatment options available if it does recur that can oftentimes again put it into remission. So I like to counsel my patients that most patients do very well despite having this lymphoma. But it's still important to be mindful that in some cases, the disease can misbehave and behave in a more aggressive way. In some cases, maybe 10, 15, 20%, the cancer can actually come back quite quickly after the first treatment. That's called POD24, when the disease comes back within 24 months of the first chemotherapy for the disease. And that can be a little bit more of an aggressive type of relapse that can be a little bit more difficult to treat. And then in a minority of patients, maybe 5 to 10%, the disease can also develop new mutations and transform into a more aggressive form of non-Hodgkin lymphoma, like diffuse large B-cell lymphoma. And that can be a more serious cancer to deal with that does require stronger treatment. So there are many different first treatment options available for follicular lymphoma, depending on each patient and their disease. Some of the most common treatment options include radiation therapy, active surveillance or watchful waiting, immunotherapy, or a combination of chemotherapy and immunotherapy, which we call chemoimmunotherapy. So we'll discuss radiation therapy first. Around 10 or 15% of patients with follicular lymphoma will present with localized disease, which you can see on the PET scan here on the right, where there may just be 1 or 2 enlarged lymph nodes and no signs of lymphoma anywhere else in the body. In that case, where the lymphoma is truly localized to that one region, we can often target it with radiation treatment, which may take several weeks to perform with daily radiation sessions, like you can see on the bottom left here. And this can be a very effective treatment with perhaps around 50% of patients achieving a very long-lasting remission. And some patients may even be cured by radiation treatment if they have truly localized disease like this. Most patients, though, present with more widespread disease. The lymphoma typically is found throughout the body, in the neck, chest, and the abdomen and pelvis. In that situation, radiation is not an option because it's simply too widespread to safely irradiate. But if the patient is feeling well, if they don't have any symptoms, and they don't have very large lymph nodes, they only have a small amount of lymphoma present, then the best treatment is actually no treatment at all. And that's what we call active surveillance or watchful waiting. We can actually safely monitor patients with regular checkups, depending on the situation. It might be every 3 to 6 months or every 6 to 12 months as time goes on. And we're monitoring to see if there are any signs of the lymphoma starting to increase over time or starting to cause any symptoms. Most patients eventually will reach the point where they need to start treatment for the lymphoma, but on average, it may not be for at least 3 years from the time of diagnosis. Importantly, though, there are some patients where they actually never require treatment. Sometimes the lymphoma can be so indolent or slow growing that it doesn't really change over time and chemotherapy is never required. And there's even a small proportion of patients where the immune system can actually reactivate and put the lymphoma into remission on its own. We call that a spontaneous remission, where the lymphoma can sometimes disappear without any treatment. There are some situations, though, where watchful waiting or active surveillance may not be preferred by a patient. Some patients may not be comfortable with the idea of observing their cancer, although we do know that it can be safely done for several years. There is an alternative option for those who prefer not to do the watchful waiting approach, where we can sometimes use 4 doses of immunotherapy or rituximab to put the lymphoma into a remission. So rituximab it's not chemo, it's a pure immunotherapy. It's an antibody that targets a specific protein on the lymphoma cell called CD20. And this antibody will then bind to and activate other immune cells, like our natural killer cells and our macrophages, to help the immune system eradicate the lymphoma cells. So this is an effective treatment that can work for people who have only a small amount of lymphoma at diagnosis. It can put the disease into remission. It probably won't cure the lymphoma, but on average, it may not come back for at least 10 years. So this is an option without too many side effects that can potentially provide some time and delay the need to actually start definitive treatment with chemotherapy for a good period of time. There are also some patients who may be older or frail or have underlying health problems where chemotherapy is maybe too risky because of the side effects. So in those situations, we may also consider treating with a fairly gentle immunotherapy like rituximab as an alternative to chemotherapy. So when do we actually consider starting chemoimmunotherapy for follicular lymphoma? So many patients will be monitored for several years until these signs of more significant disease develop. Some patients may actually be diagnosed with these signs already present and need to start chemotherapy sooner rather than later. So the most common reasons to need to receive chemotherapy are if the lymphoma is growing to a significantly enlarged size. So we typically use criteria like having any lymph node more than 7 centimeters in size, or 3 or more lymph nodes more than 3 centimeters in size to warrant starting chemotherapy. Also, if the lymphoma is starting to cause problems, like it's filling up the bone marrow and causing low blood counts, or it's causing a significantly enlarged spleen that's giving the patient discomfort, or if the lymphoma is at risk of pressing on and injuring an organ, like the kidney or liver, for example, or if the patient has symptoms from lymphoma, like they're bothered by their lymph nodes or they have significant fatigue or night sweats from the lymphoma. These are all indications the lymphoma has become active enough that we should start treatment to put the lymphoma into remission and help the patient feel better. So the most common first chemotherapy treatment for follicular lymphoma in Canada is a combination of two drugs, bendamustine, which is a chemotherapy drug, and rituximab, which is the immunotherapy medicine. These are given together on day 1 and day 2 of every treatment cycle, and we repeat that every month for a total of 6 months. So it's about 6 rounds of treatment in total. Following the 6 months of chemotherapy and immunotherapy, many patients will pursue an additional maintenance treatment, which is no more chemo, just the rituximab immunotherapy, which can be given every 2 or 3 months after chemo is done for a total of 2 years. And we know that doing this extra additional maintenance treatment can help to prolong the remission. On average, it may double the time before the cancer comes back. But it does come with some potential side effects, such as infections, for example, that we have to be mindful of. Overall, though, this combination of bendamustine and rituximab is a very effective treatment for follicular lymphoma. The average remission varies from person to person, but on average, the disease may not come back for at least 10 years. And there are some people who are 10, 15, maybe even 20 years out where the lymphoma has actually never come back. In terms of side effects to expect from bendamustine and rituximab, I often reassure my patients that this is actually a very gentle chemotherapy, and many people actually do feel generally well while receiving it. One nice advantage to this chemotherapy is that it is so gentle, it doesn't even cause hair loss in most people. But it can come with some issues. It can cause the blood counts to go down. It's rare to need a blood transfusion, but it can cause the neutrophils or white blood cells to drop low, in which case patients may be at risk of fevers or infections that could require hospitalization and rare cases to treat with IV antibiotics. Chemotherapy can also cause fatigue. There can be nausea, although we do have lots of good anti-nauseants available to help prevent that. And then some people can develop allergic reactions or rashes to the chemotherapy. Rarely, chemotherapy can cause more serious complications, like a severe infection that could land a patient in hospital, unfortunately, or rarely a second cancer, like a leukemia, can occur from damage to the bone marrow, but the risk of that is generally quite low, thankfully. There are a number of strategies that patients can use to help get themselves through the 6 months of chemotherapy smoothly. So the most important thing is to take all the medications prescribed by your physician. We will often use things like anti-nauseants or antibiotics or antihistamines to help prevent side effects from chemotherapy and help reduce the risk of infections. It's also important to monitor and report any symptoms that you develop while receiving chemotherapy and bring them to the attention of your doctor and nurse so that they can help address your symptoms and make adjustments to the chemotherapy to help make it a bit easier for you. It's also important to take good care of yourself. Try to sleep well at night, eat a healthy, well-balanced diet, drink plenty of water, get some exercise each day. Going for walks is a really good thing for your physical and mental health. And be sure to rely on your family, your friends, or counselors at the Cancer Center for psychological support to help you through the whole process. And then in general, you just want to take care of your general health as well, avoiding things like smoking, avoiding excessive alcohol, and trying to avoid people who might be sick so that you don't contract infections while undergoing chemotherapy treatment. So what happens once treatment is finished? So most patients will finish the 6 rounds of chemo, and many will receive the additional 2 years of maintenance treatment afterwards. We'll typically repeat a scan, maybe in the middle and at the end of treatment, to confirm that the treatment has been effective and that the disease is in remission. And then after that, it's really monitoring. The lymphoma usually will stay away for many, many years. So we often do checkups with patients, or they may see their family physician just to look for any symptoms or changes in blood work. We don't usually have to put our patients through routine imaging tests if they're feeling well, because the chemo is effective and the vast majority of scans do end up coming back normal. But certainly, if a patient does develop symptoms that might suggest the lymphoma is relapsing, like enlarged lymph nodes or unusual pain that's not going away or blood work abnormalities, then that certainly will be investigated with another scan and a biopsy to see if the lymphoma has returned. So what do we do if and when the lymphoma does recur down the road? So we have many different treatment options available, and the treatment will depend on the situation. Some patients who have a relapse of the lymphoma where it's again at a very small level, it's not causing any symptoms or disturbances, can again be safely monitored with active surveillance or watchful waiting, and they may be able to go some months or even some years without requiring any new treatment if they remain free of symptoms. Many patients, though, will eventually develop very enlarged lymph nodes or symptoms of the disease and require treatment. The treatment does vary quite a bit across hospitals and provinces and between patients, but one option could be to reuse chemotherapy or chemo and immune therapy. Rituximab, the immune therapy, can be used a second and third time. Or, if a patient developed a relapse within a few months of receiving rituximab, we do have the potential to treat them with a more strong or potent antibody called obinutuzumab instead of rituximab. And then we'll often combine that immune therapy with chemotherapy. If the patient received bendamustine as the first treatment of their disease, we might switch to a different chemotherapy for the second treatment. That might be a combination of chemotherapy medicines called CVP or CHOP chemotherapy, for example. But it all depends on the situation. We also have a couple of other options that are increasingly used for follicular lymphoma, including lenalidomide and rituximab, as well as autologous stem cell transplantation. And I'll talk about these two next. So autologous stem cell transplantation isn't as commonly done for follicular lymphoma as it is for other lymphomas, but it still is a good treatment option to keep in mind because it is a very effective treatment that can achieve very long-lasting remissions, lasting beyond 5 to 10 years in around half of treated patients. The downside, though, it is a very strong treatment that does come with possible serious side effects. So as a result, it's typically only used for younger, very healthy people who don't have too many other medical problems, especially if they have higher risk disease. If, for example, it came back quite soon after the first chemotherapy, we might then turn to a much stronger treatment like this to provide the opportunity for a longer lasting remission with the second treatment. There are several steps involved to doing an autologous stem cell transplant. We typically start by giving some chemotherapy to help shrink down the cancer and help improve the patient's symptoms. We will then collect the patient's stem cells using a procedure called apheresis, where we have this machine that gets hooked up to a line that will filter the patient's blood and removes the stem cells, which we then put in a bag and freeze and store for the patient to use later, and the rest of the blood goes back into the patient. The patient will then receive high-dose chemotherapy, which is designed to kill off any bit of lymphoma that might remain in their body and give them the best potential for a long-term remission. And then we reinfuse the stem cells back into the patient, just like a blood transfusion, to help the bone marrow recover from the high dose of chemotherapy. The exact treatment will vary between hospitals, but many patients who receive a stem cell transplant will be hospitalized or at least stay close by a hospital for the first 3 to 4 weeks to recover from these side effects. Once that early recovery is completed, there will be frequent checkups in clinic for the following 1 to 2 months as patients get back up on their feet. And then usually by the 3 to 6 month mark, most people are feeling better and are able to return to their usual care and monitoring afterwards. Stem cell transplant can cause quite significant short-term side effects, especially when in hospital. The high-dose chemotherapy can cause low blood counts, which require transfusions. Many patients will develop infections and be put on antibiotics. There can also be some nausea and diarrhea and mouth sores and hair loss that can occur because the chemotherapy can be quite hard on the body in general. There are also some other potentially more serious side effects like severe infections or an organ being injured, or rarely a fatal complication can occur. But thankfully, these more severe side effects do tend to be rare. But this highlights why it is very important for a person to be healthy enough to undergo this treatment smoothly and safely. There are also some long-term risks that come with stem cell transplant. Fatigue can persist for many months afterwards, as well as low appetite. There's also a risk of immunosuppression and a higher risk of infections that can last for many months after the transplant. There's also a risk of infertility, potential risks of organ injury, and very rarely second cancers can occur, just like with other cancer treatments as well. But despite that, it is one of the very effective treatments that we have for follicular lymphoma, and it is a good option to consider, especially if a patient has higher risk disease that may not respond very well to chemotherapy. We do now have access in many parts of Canada to a newer treatment for relapsed follicular lymphoma called lenalidomide and rituximab. So lenalidomide is an oral medication that's taken every day for 3 weeks of each month, and it's combined with the immune therapy rituximab, and the total treatment is given for about 1 year in total. This has the convenience of being mostly oral treatment, so there's not a hospitalization required. And it also causes fewer side effects compared to stem cell transplant. And it also causes different side effects compared to chemotherapy. This really isn't chemo. The lenalidomide is more of a immune boosting medication. So it is a bit more of a targeted treatment for the lymphoma. It may not work as well over the long term compared to stem cell transplant, but it definitely is an easier treatment to take with fewer side effects. And it usually does achieve remissions lasting at least 1 to 2 years on average, but sometimes it can work for longer periods of time as well. It can cause some side effects, including low blood counts. There can be fatigue, stomach upset, diarrhea, or constipation can occur. Some patients develop allergies or rashes to the medicine, and there can be a higher risk of blood clots as well. So many patients will take aspirin, for example, to help prevent blood clots while on this treatment. And like other cancer treatments, there is a small risk of second cancers, like a leukemia, for example, that can occur in a small percentage risk. The main challenge with lenalidomide rituximab is that it's not funded or available in all parts of Canada, but it is available in some provinces, and other provinces may be able to access it through private insurance or compassionate access programs as well. So this is increasingly being used in Canada and around the world as a second or third treatment for follicular lymphoma when the disease has relapsed, and it's a useful option to have as an alternative to doing chemotherapy. So eventually, though, most of our second treatments will stop working, and the lymphoma will eventually come back. So what do we do if it comes back and requires treatment a third time? Well, as always, there are many options available, and it will depend on each situation. Again, if the lymphoma is present at only a small amount and it's not causing any symptoms, then we can safely monitor without treatment for a period of time. If patients do require treatment, then we can often use chemotherapy again, or if we haven't used it before, we can use lenalidomide and rituximab if it's available. But just over the last year, we at last gained access to a very promising new treatment for follicular lymphoma in Canada called CAR T-cell therapy. So we've had this available for several years for other types of lymphoma, like diffuse large B-cell lymphoma or mantle cell lymphoma. But now we also have access to this as the third or fourth or later treatment for follicular lymphoma when other treatment options haven't worked. And CAR T-cell therapy is an extremely effective treatment for follicular lymphoma. The vast majority of patients respond to it and go into remission. And we know that over the long term, 3, 4, 5 years, about half of patients will continue to remain in remission. So we're not yet sure if CAR T-cell therapy can cure follicular lymphoma, but it does seem to be an extremely promising treatment that can provide a very long remission, even when other treatments have stopped working. So what exactly is CAR T-cell therapy? This is actually a very futuristic treatment that involves collecting a patient's T cells through apheresis, where we, again, filter the blood to remove the T cells. We then genetically modify them to express a specific protein or receptor called a CAR. And this protein on the top of the cell will help the cell to recognize the lymphoma and then eliminate those cancer cells. CAR T-cell therapy can cause some unique side effects. Overall, though, it probably doesn't cause as many side effects as stem cell transplant because there's no high-dose chemotherapy involved. But the main side effects that we encounter are called cytokine release syndrome or neurotoxicity. And these occur when the CAR T cells attack the lymphoma and they can release a lot of inflammation into the bloodstream that can result in fevers, low blood pressure, low oxygen, or the inflammation can affect the brain and cause symptoms like drowsiness or confusion, trouble finding words, or tremors. In rare cases, the inflammation can become more severe and require that a patient be admitted to the intensive care unit temporarily. But in most cases, the symptoms are usually mild and manageable, although they usually do require a period of hospitalization during the first 1 to 2 weeks to help monitor and treat those side effects. Other side effects that can occur after CAR T include low blood counts, but they usually do recover after a period of weeks or sometimes a few months. Infections can also occur after CAR T-cell therapy, so we often use preventative antibiotics and antivirals to help prevent infections. And then second cancers have also been rarely shown to occur after CAR T-cell therapy. All right. So what other options do we have coming for follicular lymphoma in Canada right now? So we are fortunate that our treatment options are already expanding with lenalidomide and rituximab, and now CAR T-cell therapy becoming available. You can speak to your doctor as well about any clinical trials that might be open at your hospital, because that's another promising way to access exciting new and effective treatments for follicular lymphoma. There are a few new treatments that are being developed. They may not be widely available in Canada just yet, but hopefully will soon be coming on the horizon. So one promising combination of treatments is called lenalidomide and rituximab with tafasitamab. So tafasitamab is an immune therapy antibody similar to rituximab, but it targets a different protein called CD19. And we have a large recent clinical trial that showed that adding the tafasitamab antibody to the lenalidomide and rituximab makes it more effective. It helps to prolong the remission, and it also doesn't cause too many extra side effects. So it's not currently approved or funded in Canada, but I hope that it will be in the coming years. Another promising new treatment combination is zanubrutinib, which is an oral medication called a BTK inhibitor that's commonly used in chronic lymphocytic leukemia or mantle cell lymphoma. And it can be combined with the immune therapy obinutuzumab, which is like a more potent version of rituximab. And the combination of these two treatments also does appear to be effective. Again, it's not yet funded in Canada, but I hope that it will be in the future. Another promising medication is called tazemetostat, which is an oral medicine that targets a specific mutation called EZH2 that can be found in follicular lymphoma. And this is also showing some promising potential to treat the lymphoma, and it is accessible through some clinical trials. And then I think the other most exciting class of treatment for follicular lymphoma that's on the horizon are bispecific antibodies. So this is what a bispecific antibody looks like in the middle. It's a small drug that has two arms. With one arm, it binds to and recognizes a protein on the lymphoma cell, oftentimes CD20. And with the other arm, it recognizes a specific protein on a patient's T cell called CD3. And this antibody will bring the patient's own T cell very close to the lymphoma cell and help the T cell recognize and eliminate the lymphoma cell. So this is a similar treatment in some ways to CAR T cell therapy because it uses the T cells to eliminate the cancer. But it doesn't require the special manufacturing that CAR T requires. So it's available a little bit faster. And it also doesn't cause as many side effects as CAR T cell therapy. There is some risk of inflammation, cytokine release syndrome, and infections can occur. But in general, the risk is much lower compared to CAR T cell therapy. So bispecific antibodies, they have shown very promising activity for follicular lymphoma, with the majority of patients going into remission, and on average, the lymphoma staying away for at least 2 to 3 years and sometimes longer, even though other treatments have stopped working. It's not yet funded for follicular lymphoma in Canada, but we do have bispecific antibodies now available in Canada for other lymphomas like diffuse large B-cell lymphoma, and we may be able to access them for follicular lymphoma through clinical trials or sometimes compassionate access programs. And I hope in the near future, we will also have these treatments funded in Canada for relapsed follicular lymphoma because it is a very effective and well-tolerated treatment without too many side effects. So there you go. That brings us to the conclusion of our whirlwind tour of follicular lymphoma. So the key points to remember and highlight are that follicular lymphoma is a very common indolent or slow-growing B-cell lymphoma. Many patients at diagnosis will have no symptoms and only a small amount of lymphoma, so they can actually be safely monitored without treatment for a good period of time in many cases. However, occasional patients will present with just localized disease, like 1 or 2 enlarged lymph nodes that we can effectively and safely treat with radiation, which can often provide a very long remission. For other patients who have more widespread disease, especially if the lymph nodes are getting very large or causing symptoms, then treatment with bendamustine chemotherapy plus rituximab immunotherapy is a very effective treatment that can provide many years of remission to most patients. Eventually, the disease may relapse and require treatment in the future, but keep in mind that we have many promising treatments available now or soon to come, including reusing chemotherapy, lenalidomide and rituximab, autologous stem cell transplant, CAR T cell therapy, bispecific antibodies, tafasitamab, and so on. So the future is indeed looking very bright for follicular lymphoma with all of these promising options becoming available. And with that, I'll thank you for your attention and be happy to address any questions during the upcoming Q&A.
Thank you, Dr. Puckgren, for that very informative presentation. Like it was just mentioned, I do want to take a second to direct the audience to now attend the indolent non-Hodgkin's Q&A, which will be starting in a few minutes. So you have some time to take a short little break, perhaps stretch, and then we'll see you at the Q&A. Thank you, everyone.